Respected seniors and dear friends, today we are going to talk about ultrasound for neuraxial procedures. So, someone called me for an epidural in a difficult spine patient. He is my friend, and he called me. He messaged me that I need your help for putting an epidural in a difficult spine patient. I said, trust me, I am an expert and I can put epidural in any of my patient. I was like a bit arrogant. But once he shared this photograph of CT scan with me, it was like sweat on my forehead. But then I started learning ultrasound for spine. And once I became expert or reasonably expert for doing ultrasound guided neuraxial procedure, now I can say I can put epidural catheter in any difficult spine with comparatively less difficulty. So traditionally, we were used to put epidural or giving spinal with either with anatomical landmark, or we were looking for loss of resistance, or we were visualizing the free flow of CSF through spinal needle. But it becomes difficult in patients with obesity, edema or back, or underlying spinal deformity and previous spine surgery. So level of difficulty may be unpredictable when we are doing landmark guided technique. So when we are putting the needle, we don't know how difficult it will be spinal or epidural. So we are clueless about the difficulty of the spinal or epidural. Tough line is not consistently at L4 and 5. This is a study where they found that when they draw the tough line, that is a line joining a highest point of iliac crest, only few patient had tough line at L4-5 space, and maximum patient has it at L2-3 space. Earlier, we were used to think that it is at L4 or L4-5 level, but it is not true. So when we give with landmark guided technique, we end up giving at wrong level. So question come to our mind, why we need ultrasound as compared to X-rays or CT scan. It is non-invasive, it is safe and simple to use, and it can be performed expeditiously at the point of care, and it provides real-time images. So no other technology can provide real-time images. It is devoid of significant adverse effect like radiation hazard, and it is particularly helpful in delineating abnormal or variant spine anatomy. So it is a quite useful tool which is nowadays available inside our operation theater, and we can use it for spine anatomy, sonoanatomy also. So we can do either pre-procedure scanning, or we can use real-time ultrasound guidance. With pre-procedure scanning, we can accurately look at the midline. We can identify a given lumbar interspace, so we can look for the best interspace for spinal or epidural. We can predict the depth of the epidural space by measuring it. We can identify patients in whom central neuraxial block may be difficult. So we can identify the difficulty and we can act accordingly. With real-time ultrasound, nowadays enough literature is available to support that it reduces the number of puncture attempts. It improves the success rate of epidural access on the first attempt. It reduces the need of puncture at multiple level, and it improves the patient comfort during the procedure. So it has got definite advantages, and multiple trials has proved it. But when we look at this data, we think that why it is not that popular. We know that landmark guided technique has got high success rate. We are doing it for years. We are giving spinal epidural since our residency days. So we are confident about landmark guided technique. Another important issue is there are limited data for ultrasound guided technique. It is not that popular at this point of time. Its use getting increase, but it is not that popular. Poor understanding of spinal anatomy and sonata anatomy is also an issue. And last but not least, it is like looking at the outside world through a small window. So when we do spine ultrasound, we have very small windows of interspinal space and interlaminar space, and otherwise there is bone all around. So spinal cord is surrounded by bony structure all around, and we have to look through a small window to look at the spinal cord. So if we look at the anatomy, this is the body of the vertebra, and these are the transverse processes. These are the articular processes. Here you can see this is the lamina, and it is connected to the body with pedicle, and this is the spinous process. Spinous process of thoracic vertebra is at acute angle, while it is at right angle at lumbar level. So here you can see this is the interspinous space through which our needle pass, and this is the interlaminar space. So these are the two potential area through which ultrasound beam pass, and our needle also pass through it. So when we want to do ultrasound for spine probe, we are using it curvilinear probe. You can use linear probe also in a thin and lean patient, but image you get is smaller size. So if you use curvilinear probe, you can have better idea. So I prefer to use curvilinear probe. You can do it in sitting position, lateral position, and prone position. Sitting position is preferred when you are doing for pre-procedure scanning. But if you want to put a catheter, especially in thoracic level, with real-time guidance, prone position is preferred, because holding the probe is bit comfortable in prone position as compared to sitting or lateral positions. So when we do ultrasound, we recognize certain patterns of bone during our scanning technique, and we have 6 views total: 2 transverse view and 4 sagittal views. So we look at the transverse spinous process view, transverse interspinous view, and in sagittal view there is midline or medial sagittal spinous process view, paramedian sagittal article process view, paramedial sagittal transverse process view, and paramedial sagittal laminar as well as oblique view. So what is the transverse spinous process view? When we put the probe on the spinous process, what we see this structure. So this is our spinous process, this is our lamina, and somewhere here with our transverse process. So bone doesn't allow any echo to go beyond the bony structure. So we cannot see any spinal cord structure or neural structure at this level. So we have to move the probe at the interspinous view level. So here there is spinous process, above spinous process will be somewhere here. So if we go in the interspinous view, we can see the neural structure. So we have to move the probe like this, either cranially or caudally. So once you move the probe cranially or caudally, you can see some different structure. These are the articular processes. This is the lamina, this is the transverse process, and you cannot see spinous process here. You are looking at between 2 spinous process. So this is your posterior dural complex, and this is the anterior dural complex, and this will be the spinal cord. So this is the epidural space, and this is our target area. So once we get this picture, we can measure the distance from here to here to define where our epidural space will be. According to the angulation of the probe, we can see which direction in which direction our needle will go. So this view is also called a cat head appearance. So all the views are given some names so that you can recognize that pattern and you can memorize it. So once you move, make the probe little oblique, you can see you can see nicely dural complexes, and you can put the epidural catheter at this level very easily. Now medial sagittal spinous process view. Now probe is in the vertical direction. So once you put the probe in this direction, what you find is this is our sacrum, this is the L5 spinous process, this is the L4 spinous process. Actually, aspect marker should be on the cranial side, but I kept it by mistake on other side, on the caudal side. So if to make you remember this thing, I have kept this image intentionally so that you can understand it should be on the cranial side. So our image should be totally reverse. When you go in the paramedial sagittal laminar view, what you see is the horse head appearance. So lamina looks like a horse head. So once you get this appearance, that is the view of lamina. And when you make the probe oblique, you will see this posterior dural complex and anterior dural complex at the level, at the lumbar level. At paramedial articular process view, we go further laterally and we will see these structures like this. So these are continuous structures and you don't get any space in between. So it looks like the hump of the camel. So this is called camel hump appearance. So articular process view is camel hump view. Paramedian sagittal transverse process view, once you move the probe more laterally, you will find the transverse process view. And transverse process is like either it looks at the tip of the fingers, or you can see it is like a trident appearance. So this is called trident appearance. So there are three view from midline to lateral. First is lamina, that is horse head, then camel hump, and then trident appearance. After getting the view at the level of facet, when you make the probe little oblique, what you see is, as I said, you see the laminar view, interlaminar view, but by making it oblique, you will see the posterior dura as well as the anterior dura. You can either come from here to here with out of plane technique, or you can even go with in plane technique. You advance the needle up to this level and you can have epidural. And when you are doing spinal, it is suggested to go from the low. If you look at the midline, you should not insert the needle from above. You should insert the needle from the below of the probe when patient is in the lateral position, because if you insert your needle from above, it is easier for you. But there is one study where they found that CSF flow is not seen even if you are in the right place. But if you go from the dependent side, you will get the CSF easily. So in nutshell, this is the transverse process view, the trident view, then pyramidal sagittal articular process view, that is camel hump, and then laminar view, that is sawtooth or horse head. And then once you make the probe a little oblique, it will give you posterior as well as anterior dural complex. And this is transverse interlaminar view. So these are the view by which we can have, and we can put the spinal or epidural in the lumbar region. This is diagonal oblique view. So if you want to give epidural with in-plane technique in real-time guidance, you can make the tip of the probe tilt the tip of the probe a little medially, so that you can see the spinous process and the lamina. So once you get this view, you should advance the needle and look for the you can see the needle tip up to the lamina. Once you get there, you have to look for the loss of resistance and then advance the needle, then put the catheter once you are in the epidural space. So what is our goal when we are doing all this process? Our goal is to identify the interspace. Once we identify the interspace and the midline, we should look for the depth of the epidural space, and we have to mark the needle insertion point, and we have to look at for the angle also. So when we do pre-procedure US assisted midline approach, we have to confirm the midline based on the spinous processes. So we have to mark the spinous processes and we have to mark the midline. Locate the interlaminar space and choose the most appropriate intervertebral level for neuraxial puncture. So we have to start scanning from the sacrum, then advance the probe cranially and look at different interlaminar spaces and the interspinous processing. And when we get the best view, we have to do either spinal or epidural at that level. Determine the needle insertion point and angle of needle trajectory using the transverse interlaminar view. Estimate the depth of needle insertion by measuring the distance from the skin to the posterior complex. Perform the unidirectional block by inserting needle at the predetermined insertion point with the insertion angle. So in the where the ultrasound beam travels, in the same direction our needle will travel. So it should be in the same direction to get the proper spinal or epidural. But we have to remember, when we are doing scanning, especially in obese patient, if we apply some pressure, it will compress the subcutaneous tissue and the fat. So measured depth will be lesser in comparison to real depth. So we have to be careful about not applying too much of pressure while measuring the depth. So as I said, for interspinous, for transverse view, first we look at the spinous process, then we go downward between two spinous processes in the interspinous view. Once we get it to get the proper posterior and anterior complex, we can tilt the probe and look at the best picture and then estimate the depth, and then we can go for the procedure. Pre-procedure US assisted Paramedian approach, we have to confirm the midline with the transverse process view and apply probe in the longitudinal direction 1 to 2 centimeter lateral to the midline with a slight medial tilt. So we mark the midline, then we go make the probe vertical or in the sagittal plane, then we make the probe little oblique towards the spine to see the interlaminar view. Identify the interlaminar space in the parasagittal oblique view and select the intervertebral level that provides the largest interlaminar space. And it is usually L4-5 or L5-S1. Most of the time it is L5-S1. Determine the medial angle of the sagittal plane that provides clean image of the interlaminar space. So we have to look at the angle also. Estimate the depth of needle insertion by measuring the distance from the skin to the posterior complex. Insert the needle at the designated insertion point with the designated angle. So angle should be designated and insertion point should be also designated so that we go at the right place. So how to do scanning? This is in volunteer. So here you can see I've kept the aspect marker on the cranial side. I've selected the curvilinear probe. I will start scanning from the sacrum. Here you see I have kept a pen for marking. So I've kept the probe on the midline or slight paramedian. We can in the paramedian region. This is the sacrum. This is the L5. Then this is L5. Then L4. Once we find the L5 and L4. So we have found the L5 and L4. Then we will see that different images of this is the transverse process. This is the transverse process of L3, L4, and L5. So my probe is roughly 3 to 4 centimeter lateral to the midline. Now I am tilting, going medially. Here you can see this is camel hump appearance. And that is because of articular process. I have gone little more medially, and you can see the lamina. And I'm tilting the probe medially, and you can see this is the posterior dural complex, and this is the anterior dural complex. This is my L5-S1. It is the widest space, and you can see CSF movement inside the dura also. So once you get it, you can put your epidural catheter at this level, or you can do spinal with either out of plane technique or in plane technique at this level. So this is the paramedian sagittal view, laminar view, oblique view to get the epidural or spinal. So this is very simple. So once I get it, again I will look at the sacrum and L5 vertebra. Here you can see this is my L5 vertebra, and I will make my probe transverse. Once I make my probe transverse, you can see this is the spinous process. This is the lamina. I will move the probe bit cranially to look at the interspinous process view. So here I am getting the interspinous process view. These are the articular processes, and this is, you can see, posterior dura. So you can measure the depth from here to here to confirm the distance between the skin and epidural space. and at this point you can insert your epidural catheter. In old age patient, interspinous ligament are calcified, and sometimes you cannot see this view properly because of calcification of interspinous ligament. So once I get it, I'll mark the points. I have 4 points, and then I'll join it to look for my needle insertion point. So I mark all 4 points. I'm joining it. Once I join it, intersection of this point will be my insertion point. My probe was perpendicular, so I'll insert the needle perpendicularly to get the spinal. So this is how you can do it. For thoracic spine, you can use ultrasound as well, but here there is difference because spinous processes at the level of thoracic spine are at acute angle, especially when you go at mid thoracic level. At lower thoracic level, it is similar to lumbar spine, but at mid thoracic and higher thoracic level, it is at acute angle. So it is difficult to get the interspinous view because spinous processes are at acute angle. And when you go laterally, when you look at the lamina, they are a bit flattened, and even interlaminar spaces are very narrow. It is 0.8 centimeter at lower thoracic level. At mid thoracic level, it is 0.6, and at upper thoracic level, it is 0.4 centimeter only. So they are a very narrow window. So it is always difficult to get epidural. But once you get this, you can insert the needle through this. Once your needle is here, you can advance with LOR technique and you can have epidural. So how to do scanning? So for thoracic spinal, you have to look at the 12th rib first. This is 12th rib. This is 11th, 10th rib, 9th rib. Now I want to put the catheter at T9, 10 level. So I will move the probe medially. Once I get this image, I'm moving my probe medially slowly. I'm going medially. So once I go medially, I'm getting the laminar view. So once I get this view, I make the probe little obliques toward midline, and you can see this is the posterior dural complex, and somewhere here is this is the anterior dural complex. So this is my target area, that is a complex of ligamentum flavum and posterior dura. So I can insert the needle from here to here. But if you make the upper part of the probe tilted toward the midline, you will have a better view of this window, and you can go in with in-plane technique in real-time guidance, and you can have successful epidural with comparatively less attempt. So here you can see I have tilted the tip of the upper part of the probe medially, and you can see somewhere here will be the spinous process, and this is the lamina, and you can go through this point and advance your needle with in-plane technique. So this is how you can do thoracic epidural. It is usually done in the prone position. Here you can see how to do real-time ultrasound. This is the rib first. Then you go medially, transverse process. Then this is the lamina, and you make the probe little oblique medially. Then you make your tip upper part of the probe tilted towards the midline, and this is where you put your needle. Here you can see my needle is coming in plane, and you can insert the needle. Once you are near the lamina, you have to look for the loss of resistance and then put the catheter. So you can do thoracic epidural with this technique. Some difficult scenario like scoliosis, where spinous processes are angulated in a different angle, at various angle. So you have to mark the spinous processes at different level. You have to look for the spinous processes with transverse spinous view. You mark it. Once you get the curvature, you should go from the convex side of the curvature. From convex side of the curvature, you will get the interlaminar view, and you can put your spinal or epidural through it. But once you have to learn the things first in the normal portion, then only go for patient with such deformity. Operated spine patient, again, we have to look for the best space where we can insert epidural, and then only we should go for procedure rather than attempting it blindly. In geriatric patient, as I said, because of calcified ligaments, sometimes difficult to get midline access. So you should go with Paramedian approach through the interlaminar space. We have such spine models. Simplest of it is a water bath. You used to put a spine model inside a water bath, and then you can do the scanning with your ultrasound probe, and you will get such nice images so that you can correlate the thing very nicely. So this is the spinous process view. This is interspinous view. So with spine model, you can understand the various bony structures, anatomy and anatomy, and then you can apply the things in the normal patients and then into difficult spine patient. Here, this is these are the images with our spine model. This is the interspinous view. This is the article process view. So you can do this practice with this thing, and then you can try it on human beings. So spine ultrasound is and ultrasound assisted neuraxial blocks is little advanced technique. We are looking at neuraxis from very small bony windows, and step-by-step learning in normal patient and applying that knowledge in different difficult spine patient is the way to master it. It looks difficult earlier, but once you learn the process, it is very simple and you can master the technique. So this is all about spine ultrasound. Thank you for patiently listening.